Welcome to this explainer. Today, we are going to trace the fascinating, totally microscopic journey of the hepatitis A virus. We're going to follow its path straight from the outside world, down into the digestive tract, and directly into the human liver. It's an absolutely incredible sequence of events that triggers a massive, full-body response.
We really have to ask, how can a simple plate of raw shellfish, or just a totally normal trip to a daycare center, completely hijack your immune system and literally turn your skin and eyes yellow? Well, by the end of this explainer, you'll know exactly how this wild biological domino effect actually happens.
Let's jump right into Section 1, the virus and transmission.
To understand how this virus spreads, we kind of have to look at what it actually is. Structurally, the hepatitis A virus, or HAV, is incredibly simple. It's an RNA virus. Specifically, it's a positive-sense single-stranded RNA virus. And crucially, it's non-enveloped. In virology, we literally call this a naked virus, which just means its precious genetic code is protected by absolutely nothing other than a tough outer shell of capsid proteins.
But because of that tough, naked structure, it survives perfectly fine outside the body, which allows it to travel via the notorious fecal-oral route. It's an unpleasant but highly efficient four-step transmission cycle. Basically, it moves from infected feces to unwashed hands. From those hands, it transfers right into contaminated water, raw or undercooked shellfish like oysters, or shared objects like daycare toys, before being ingested orally by the next unsuspecting host.
Moving on to Section 2, Journey to the Liver. So once you actually ingest the virus, it kicks off this incredible journey from the digestive tract. It travels down the esophagus, through the stomach, and right into the intestines. Down there, it gets absorbed into the mesenteric veins, diving into this massive convergence of blood that forms the portal vein. You can think of the portal vein as a direct, high-speed highway delivering the virus right into the liver's functional cells, which are called hepatocytes. The virus binds to a receptor, gets swallowed whole by the cell through endocytosis, and immediately hijacks the host cell's ribosomes. It forces the cell to translate its RNA into one massive polyprotein, which is then chopped up by a viral protease enzyme to just mass replicate the virus.
Now, what's really fascinating here is how the newly replicated virus makes its escape. It takes two distinct exit paths from the liver. Path number 1 drops the virus directly into the bloodstream, causing viremia. This means we can actually detect the viral RNA in a patient's blood using a PCR test. But the second path? That's the sneaky one. The virus is shed directly into the biliary system, flowing down the bile ducts right back into the intestines. This allows it to be excreted and successfully infect others, completely closing that transmission loop we saw earlier.
Which brings us to Section 3, the immune counterattack.
Up to this point, the virus has just been quietly mass-producing itself. But here is the major twist. The virus doesn't actually kill the liver cells on its own. If we map this out on a timeline, local immune sentinels in the liver, called Kupffer cells, detect the viral replication within the first week or two. They sound the alarm by releasing inflammatory cytokines, and this brings us right to week 2 or 3, known as the prodromal phase. The patient suddenly gets hit with a fever and deep fatigue. Crucially, all this inflammation causes the liver to swell up, pushing hard against its outer covering, known as Glissen's capsule. Because Glissen's capsule is absolutely packed with nerve endings, the stretching causes very specific, localized right upper quadrant pain.
This really highlights our core conflict here. The liver injury we see in clinical practice is actually friendly fire. It's our own immune system forcefully destroying our own cells in a desperate, scorched earth attempt to clear the viral infection.
Let's look at Section 4, Clinical Signs and Symptoms.
So this microscopic immune warfare rapidly progresses into the visible, clinical signs that actually bring a very frightened patient into the clinic. The adaptive immune response kicks in with the heavy artillery. CD8+ cytotoxic T cells arrive on the scene. They identify the infected hepatocytes displaying viral antigens, and they literally blast them with specific enzymes called perforins and granzymes. Perforins punch physical holes in the liver cells, and granzymes go in and force the cells to undergo apoptosis, which is programmed cell death.
When these liver cells essentially explode from this targeted T-cell attack, they dump all their internal contents straight into the bloodstream. This causes lab results, specifically liver enzymes like ALT and AST, to spike massively, often into the thousands. When a clinician runs blood work and sees ALT and AST levels that high, acute viral hepatitis is immediately at the absolute top of their differential diagnosis.
And all of this cellular destruction leads us into the infamous icteric phase. The severe inflammation and edema physically pinch the biliary ducts completely closed, a condition known as intrahepatic cholestasis. Because those ducts are pinched, bile simply can't drain. So bile salts back up into the blood and deposit in the skin, causing severe, maddening itching called pruritus. Bilirubin backs up too, staining the skin and the whites of the eyes a yellowish-orange hue, which we all know as jaundice. That backed up bilirubin also spills over into the kidneys, turning the patient's urine dark. And finally, because normal bilirubin isn't making it into the intestines to be converted into stercobilin, which is the pigment that naturally makes poop brown, the patient's stool ends up looking totally pale, almost like clay.
Next up, Section 5. Diagnosing the infection. When someone shows up with all these intense symptoms, the absolute crucial first step is figuring out exactly what we're dealing with to definitively diagnose this acute viral infection. To confirm hepatitis A, we look directly at the patient's serology markers, specifically their antibodies. Anti-HAV IgM is our fast-acting first responder. You can remember M stands for a minute ago. Its presence tells us there is an active acute infection happening right now. On the other hand, anti-HAV IgG arrives later and stays forever. If a patient only has IgG in their blood, it means they've already cleared the virus in the past or they were successfully vaccinated, so they now have lifelong immunity.
Now, while diagnosing, clinicians absolutely have to check a blood clotting test called the PT/INR. You must watch out for a PT/INR score greater than 1.5. See, a healthy liver produces vital blood clotting factors. If the liver becomes so damaged that the PT/INR climbs above 1.5, it tells us the liver is actively failing to make those proteins, leading to a highly dangerous coagulopathy where the patient could bleed uncontrollably. That high PT/INR, it's a massive red flag for acute liver failure. Now, I should mention, this is rare. It happens less than 1% of the time, but it usually occurs in patients who already have a pre-existing compromised liver, something like a hepatitis C co-infection. In acute liver failure, the liver simply stops converting toxic ammonia into urea. So, ammonia rapidly builds up in the blood, crosses into the brain, and draws water with it. This causes cerebral edema, or brain swelling, leading to hepatic encephalopathy. The patient will exhibit severe confusion, a distinct flapping hand tremor called asteraxis, and potentially even seizures.
Finally, let's cover Section 6, Treatment and Prevention.
Fortunately, even though these symptoms sound absolutely terrifying, modern medicine has incredibly effective ways to handle us. You might expect we'd use some complex cocktail of antiviral medications, but actually, hepatitis A is almost always a self-limiting disease. We don't even use antiviral drugs for it. The primary treatment is just simple supportive care, keeping the patient hydrated and managing their symptoms while their own formidable CD8+ T cells clear out the virus completely on their own. And importantly, it does not progress to chronic hepatitis.
Even better, if someone realizes they've just been exposed, let's say there was an outbreak at a local daycare or a restaurant, we can actually stop the disease in its tracks using this post-exposure prophylaxis matrix. If the patient is healthy and over 1 year old, we simply give them the hepatitis A vaccine. If they're under a year old, we give them direct hepatitis A immunoglobulins, which are basically instant ready-made antibodies to neutralize the virus. And if the person is immunocompromised or has chronic liver disease, we absolutely don't take chances. We give them both the vaccine and the immunoglobulins to make sure they don't spiral into that dangerous acute liver failure we talked about.
It's honestly mind-blowing when you think about it. This intense, full-body immunological warfare, the swelling liver, the yellow eyes, the brain-swelling ammonia buildup, all of it can be entirely prevented before it even starts. All it takes is a highly effective vaccine or just the fundamental, everyday practice of basic hygiene. Which really leaves us to wonder, after seeing exactly how this invisible RNA virus travels directly from someone's gut right into your liver, will you ever look at a raw oyster or an unwashed hand the exact same way again? Thanks so much for joining us for this explainer, and keep learning.